Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast. My name is Terry Fletcher. Happy to have you with me today on this great Tuesday. Today, we're going to talk about something called coding yes or coding no. One of the things I've been running up against in the last week or two, not just in auditing, but just in the questions I've been getting from my Coding Corner clients and then talking with other potential clients and also some physicians and staff, I'm finding that there's a lot of assumptive coding going on out there, meaning that some staff or coders or billers or whoever is in charge of the coding are speaking for the physician in regard to coding when the documentation does not support what's being sent to the insurance company. So we really need to talk about that and have you understand how dangerous it can be to assumptive code. And it's actually really easy to do that. You know, how many times do you finish your partner or your spouse's or girlfriend or boyfriend or anybody's sentence, your child's sentence? I know my daughter does it to me all the time. You can't do that in healthcare, in coding, in documentation, and it's a problem. So we're going to tackle that topic today. But first, I wanted to say hello to Carolyn and Jill, some loyal listeners that have sent me some nice messages on LinkedIn. And if you do the same, shout me out. Let me know that you're listening. You can hit me up at LinkedIn. You'll find me at Terry Fletcher, Twitter, TerryCoder1, Instagram, Terry NCA, Facebook, Terry Fletcher Consulting. And I'd be happy to say hi and shout you out on the show. So, and also send me your topics. I've been getting a lot of some feedback, or I should say some queries on, hey, Terry, can you help with this? Or can you make this a topic? I love that. We are at episode 81, and every single episode has been a different topic. So that's hard to do, and it's hard to do all by yourself. So if you can give me some topics or things that you want to hear, I know I sometimes focus on cardio and GI and ortho, and I've started to open up to a little bit of integumentary, and I know I do family practice. You've also seen a lot of auditing. I've also talked about HIPAA and compliance plans as well. But just we try to be all over the map on this. So if there's something that you're not hearing on the CodeCast, let me know, and I'll see if I can open up that topic for you. So send me your ideas, your suggestions, anything that we can get on the air for you. Happy to do it. We have over 52,000 listeners, and we want to see if we can appease everybody, or at least speak to everybody. That's really what we want to do with this. So let me move on with my topic here, and I want to give you some kind of examples of what it means to not assumptive code and what it means to assumptive code, just so that you can be careful. We are very much in tune with our physicians, and even I'm in tune with my clients. And when I audit for a practice, all of a sudden I'll notice saying, okay, so I know they meant this, and I have to take a step back because we never want to code based on what we think the physician or provider meant to say, but what they actually did say. I'm sure you've heard the coder's motto, if it's not documented, it's not done. Well, this could not be a better example of making sure that it is documented before you move on with reporting a service just because you think that's probably what it should say. And I know that might sound silly to you, but you'd be surprised how many records I look at where someone will say, hey, I coded it this way. Can you just confirm that I coded it that way? And we do that if you're a Coding Corner client. You know, you can send over a report and basically we'll double check for you just so you can have some confidence that it's correct or not. And 9 times out of 10, when somebody's concerned, I'll say, wait, where is this in the report? I'll see it in the header, but I don't see it in the report detail, and that's a problem. So one example that happens a lot is now with the new moderate sedation codes. They came out last year, and there were some codes that had a symbol on it that looked like a bullseye, and so that were inclusive of the moderate or conscious sedation. So when that symbol was taken off, many procedures, I think over 200, the value of those procedures went down about 2 to 4%, or anywhere from $10 to, I think, $45. And so you want to capture the additional code now that they give us if you actually performed supervision that was well documented, you get to actually code a 99152 or in that area, and you just want to make sure that it's well documented. Now, we're not talking about monitored sedation. We're talking about moderate. Monitored sedation is general sedation, and there's completely different codes in the 00 code series. This is monitored sedation in the medicine section, 99152 and so forth to 99157. And so the thing is about this is that I'm seeing physicians will say in their report, Versed or Benadryl, conscious sedation, see nurse's sheet. You can't give them anything on there. So I'm seeing offices saying, oh no, that's enough. No, it isn't. The one thing about this code is it says your direct supervision. So even in the language on how to use the codes, you also have to include time on your report. This is a time-based service. So if you don't say under my direct supervision or I supervised or, my nurse and I participated in something that shows that the nurse isn't the only one that's monitoring the service. You are as the physician, plus you're putting in time and what medicines you used, then you can refer to the nurse's sheet. You can't capture that code. And I see a lot of practices trying, and that's a problem because now the payers are starting to ask for it back saying, I see no information here that says that you supervise this sedation administration. So make sure that is in the report. Don't assume just because you have medicine and time that that's all you need. Now, coding from the op report, again, the procedure note header. So for example, gastroenterology. You have a patient who had multiple polypectomies, so they removed polyps from the colon through colonoscopy. And let's just say a coder assumes that a snare was done, 45385, but then you get into the report and you realize that it was a cold biopsy forceps. Do not assume something just because it's in the header. It has to be in the report detail. I see that all the time. So, and I'll give you a couple other examples of different specialties as we move forward, but that's a really, really big deal when you're seeing it in the header, which is really just a list of what the doctor anticipates to do, but it's not necessarily what they did do. The next assumptive coding issue that I see are signs and symptoms. So a patient can be diagnosed with polyuria, polydipsia, which is excessive thirst or urination. And then diabetes is coded without lab confirmation. One of the more dangerous ones I saw recently, oh my gosh, scared the heck out of me. Basically, the patient had a breast mass and they coded it as breast cancer. You cannot assume that a patient can make that leap without pathology, without lab tests, something that confirms that diagnosis medically or clinically, or the physician has confirmed it. As a coder, as a biller, as an administrative healthcare professional, that is not up to you to assume what it is until you have confirmatory lab tests or clinical information and documentation. One of the things that came up with some of the new codes for the new Inr testing, so a patient is a warfarin or an anticoagulant patient who's on blood thinners, so the ProTime documentation, the 93793, so a physician or mid-level notes in the chart, quote, patient on warfarin, levels normal, 2.1 INR, no adjustments needed. That's all they did. And now somebody's trying to code the 93793. Well, where is the entry of the date and where the lab test was done? Part of that code actually specifically says that a new lab test in home, office, or lab was done, and that there was also a conversation with the patient. So you have to also have evidence of a phone call or a face-to-face, and you cannot assume that that was done. This is just saying basically that they read a test, but they didn't necessarily have patient interaction, and that has to be in the chart. You have to be able to prove that to be able to bill that code. And this is something that the payers are just starting to pick up on and are asking for refunds. That's a really unfortunate thing. Another one is an op report that says, and here's an interesting example. So this is a cardiology example, and I probably see this more often than not. It's almost routine now. So during a heart cath, let's say, it says catheter advanced to the proximal aorta, or the level of the renals, and a doctor will document selective visualization of the renal arteries. So for those of you that are not familiar with renals are the poles or the blood supply to the kidneys. Those are the arteries. And when patients have hypertension or aortic insufficiency, those areas can become inflamed, and it could cause renal failure or blockages or occlusions, and so they may need to intervene. So that's why they would do an angiography to take a look at those renals. But the thing that the doctor said here was that the catheter was only advanced to the aorta, meaning the catheter did not selectively go in to any of the renal arteries, not the right, not the left. If there was any kind of accessory renals, extra poles to those kidneys, they did not selectively engage that area. They selectively visualized. So here's where not only do you need to make sure you understand what's being documented, but understand the rules for the services. So when the catheter is placed at the proximal aorta or at the level of the renals, that's still considered non-selective. So the injection is in the aorta, and that's just an abdominal aortogram. Regardless if the physician says I selectively visualized the artery, that's not going to get them a selective catheter placement into the artery unless they say, I advanced the catheter into, I guided, negotiated, selectively engaged, something that gives you that information specifically in the report detail. But what happens sometimes is that coders will look at that and see selective and not read further, or will make an assumption that they purposely put a catheter in that structure and try to code for it incorrectly. Huge overcoding and major mistake. So we want to really be careful in that scenario. In orthopedics, I've seen in headers that state we did a rotator cuff repair through arthroscopic means, and we did an arthroscopic distal clavicle excision. And then the detail has no mention of the distal clavicle, no mention of any size of the clavicle piece that was taken out, and you have to have at least 1 centimeter to be able to code for it. And all the report actually says is something about articular shaving or a minimal debridement. And because, again, the coder only looked at the header, that's a problem. So you have to have that report detail. Another one would be an E&M admit or hospital admit or a new patient visit. And hear me on this one, where no family history was taken. So you need 3 elements of that past family social history to be able to capture either a new patient visit or a new hospital code, which is actually a new encounter because it's still for an established or new patient, but an initial hospital still has the same rules as new patient visits, let's say in the office setting. But that element alone can take you from a 99223, which is the highest level in patient hospital admit, down to a 99233, which is a subsequent hospital service, which only needs 2 out of 3 services. So basically the history would be negated in that scenario. Or if you're trying to bill a level 5 in the office, new patient visit, 99205, without that family history, or let's say that you have a chief complaint that just says patient here to establish care, you're down to a 99201. It takes you that far down. And so you really need to pay attention to not only the details, but do not assumptive code. You also need to be willing or be brave enough that when your doctor messes up or there's non-compliance, or any provider, if it's a mid-level, to let them know they cannot capture the service because it wasn't documented. This is on you as well. So be very careful with assumptive coding. I see it all the time. I see it in ICD-10. I see it in CPT. And, it's kind of like human nature. Again, finishing somebody's sentence, knowing what you think they mean. You need to take a step back and realize that they have to tell you what they mean. Documentation is the key, and you really need to let them capture their own service based on what they document. Otherwise, it can not only fall back on the physician, but you as well. So I've received a lot of coding questions this week on the 59 modifier. And since next week, May 22nd, is my modifiers webinar, and that many of you have registered for, I appreciate that. And there's some that haven't. So I wanted to give you a preview of what I cover in the modifiers webinar, and you'll get materials with it as well. By the way, it's also available on demand. So if you're not able to attend on the 22nd, if you still purchase it, just let us know if you prefer live or on demand, and then we can send it to you after it broadcasts. But what I'm going to do is I'm going to talk about the 59 modifier and just give you some examples so you know what to expect if you did actually participate in the webinar, whether it be live or on demand. This way you know what you're kind of in for. And we also are doing it as a multi-specialty. So you'll see everything from family practice to cardio to peripheral vascular, ortho, skin, OB-GYN, ENT, GI, and more. So we try to really serve as many specialties as we can. So a couple of things when it comes to the 59 modifier, and I think you'll find that this discussion will be because I believe that it's really a misunderstood modifier, but Medicare is pretty specific on what you can do, and they've put out some transmittals and guidance on the 59 modifier. We've got a Medicare Claims Processing Manual, Chapter 23, with an updated transmittal as well from December 28th of last year even on the 59 modifier. And then the MedLearn Matters articles. This is the outreach and education by Medicare that they use in the NCCI edits and tools. They also put out some information. And so we will give you links to all of that so you see the resources if you attend the webinar. So let me just give you basically some tidbits so you can understand where we're going here. So whether you've been in the coding world for 5 years, 15 years, you have to know the 59 modifier exists. So this is called a distinct procedural service. It's also known as the unbundling modifier, but when it comes to unbundling, the CCI edits, so the National Correct Coding Initiative, or National Correct Coding Institute, I should say, and then PTP edit pairs. Now, PTP means procedure to procedure edit pairs. You need to know all of the guidelines and your modifier options when these things come up for the 59. Otherwise, it could trip you up and possibly red flag you for an audit if you use it incorrectly. So here are some of the coding questions I've recently received, and I've incorporated into giving you some tips here. So somebody says, can you just explain the CMS rules for 59? So in a nutshell, CMS puts it this way in their processing manual. They say 59 modifier is, if used appropriately, it is used for different anatomic sites during the same encounter only when procedures are performed on different organs, different anatomic regions, or in limited situations on different non-contiguous lesions in different anatomic regions of the same organ. 59 is used appropriately when the procedures are performed in different encounters on the same day, and 59 is used inappropriately if the basis for its use is that the narrative description of the two codes is different. And so you have to be careful with how you're using this modifier. The manual then goes on to document limited circumstances that may warrant the 59 use for timed procedures or diagnostic and therapeutic options, and we'll be sure to give you some of those examples during the webinar. So another question comes up, says, can you append the modifier 59 when the modifier indicator of a PTP pair is 0? Remember, that's in the CCI edits. Again, the PTP is a procedure to procedure edit pair. So the answer is no. You can only append modifier 59 or any other modifier for that matter to unbundle two procedures when the modifier indicator is 1. If it's 0, there are no circumstances, none, in which both procedures of the PTP pair code should be paid for the same beneficiary on the same date as the provider service by the same provider. Another question, is the 59 modifier the only modifier that you can append to unbundle procedures? So modifier 59 is not the only modifier you can use to unbundle. It is the situation that allows that 59 to be unbundled. But there may be some specific anatomic sites, including RT or LT, and those are modifiers for right and left side of the body. There's also modifiers for specific fingers, F1 through F9 and FA, and toes, T1 through T9 and TA. Additionally, now we know since 2015, you've also had the option to use one of the subset modifiers or the X modifiers. They introduced those to replace the 59, or I should say, it's not so much replaced because the 59 still exists, but it's instead of. So when there's no other modifier that in the X modifier section, which are subsets, that you can use, then you would go back to the 59. But for example, XE is separate encounter, XS is separate structure, XP is separate practitioner, and then the XU is unusual non-overlapping service. And I'm getting a lot of payers that are non-Medicare are starting to recognize these modifiers almost straight across the board. Make sure you still ask your contractors or ask your payers to make sure that they do recognize them. But the X modifier is better define why you feel the need to modify the service you're submitting. It's important to understand the payer again when you're using them. Can you use a modifier 59 with evaluation and management codes? The answer is no. I mean, never. You would never use a 59 on an E&M service. If you're trying to override an edit pair for an E&M's code, you should instead look at either 25 or 57, whether it be a significant separate service or a decision for surgery. So what would be an example? And I'm just going to give you one example of when you could use a 59 modifier. I'll give you a cardiology example. So let's just say that the cardiologist performs an EKG, so an electrocardiogram, and then decides on the same date that the patient needs a stress echo. The cardiologist is in the office setting, and he provided all of the components of both tests. So because one led to the other, meaning the EKG told the physician that there's an abnormality that we need to take a closer look at, you can report the stress echo with the 93351, and then you would report the EKG with a 93,000 code with a 59 modifier. Now, you may be using an XE or an XU depending on your payer's preference, also explaining the circumstance. So sometimes they want the XU because it does overlap into a stress echo, but make sure you only append the modifier XE if it's truly a separate encounter, like the patient must leave the office and return later the same day, but this is when you're still on the same date. So hopefully this will give you some insight into what our modifiers webinar is going to be. Take a look at my website at terryfletcher.net, click on the webinar tab, and hopefully you'll join us next week for that topic. Today's coding question was brought to you by Keck Medicine of USC, 500 internationally renowned doctors at a leading academic medical center, keeping you healthy, on track, and doing the things you love. The Keck Effect, keckmedicine.org, Los Angeles. So my personal tidbit this week, it is actually Mother's Day weekend coming up. I'm actually recording right before the weekend. You'll get this on Tuesday. So I can't tell you the outcome because I don't know it, but I know my daughter and I are going to go to a Dodgers game. And I can't wait for my Dodger dog and a cold beer and just to sit there. Now, I'd like to say it's the sun, but we're expecting a very cloudy weekend. But if you know me at all, I am Irish, so I have very fair skin. And so I will get sunburnt. I will get sunburnt sitting in the clouds. I kid you not. In a house I used to live in, we had a skylight in the living room, and I fell asleep in the living room one day. And I guess half the sun was on the right side of my body, and I got sunburnt. Seriously, in my house. How sad is that? That is crazy. But anyway, I'm looking forward to a really fun Mother's Day weekend, just spending some time with my daughter. We're both off. We're not going into the office. She's taking a break, and we're just going to hang out. So I'm really looking forward to that. So for all you moms out there, grandmothers, to moms-to-be, stepmoms, and you know what? Even if you're moms of pets, have a great weekend and just make it a great day. And we look forward to talking to you the next time on the CodeCast podcast. Thanks for listening.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.